Hi class, I'm Dr. Five, and today we're going to go over structure and function of the neurological system and some alterations that can occur as well. I apologize in advance, I have really bad allergies today, and my voice is having a difficult time with this, but we will get through this. Okay. So looking at structure and function of the neurologic system, we can first talk about the cells of the nervous system. The neurons, this is the primary information and communication cell of the nervous system, and it uses glucose as its fuel source. The neuroglial cells, these are found in the CNS and PNS, and can provide structural support and nutrition to neurons, remove debris, increase the speed of nerve impulses, and can be used for processing and storing of information. The neuroglia comprise general classification of cells that support the CNS. They make up about half of the total brain and spinal cord volume. Examples include astrocytes, oligodendrocytes, Schwann cells, ependymal cells, and microglia. Now, the Schwann cell, or the neurolimocyte, is a glial cell that wraps around and covers the axons in the peripheral nervous system, and they form and maintain a myelin sheath and the nodes of Ranvier. Now, neurons are not physically continuous with one another. There are synapses, which are a region between the adjacent neurons. And we have about 4 to 6 different neurotransmitters that are affecting in the nervous system. And these include norepinephrine, acetylcholine, dopamine, histamine, GABA, and serotonin. The central nervous system, we have the brain, which has 3 major divisions: the forebrain, midbrain, and hindbrain. The forebrain, there's 2 cerebral hemispheres. The midbrain, there's the corpora quadrumina, the tegmentum, and the cerebral peduncles. The hindbrain is the cerebellum, pons, and medulla. Now, the brainstem is made up of the midbrain, the medulla oblongata, and the pons. Now, the spinal cord, this lies within the vertebral canal and is surrounded by the vertebral column. Functions, there's a long nerve tract that connects the brain and the body, and there's conducting somatic and autonomic reflexes and providing motor pattern control centers, sensory and motor modulation center. Now, we have afferent or sensory neurons and efferent, which are motor neurons. There's different sections. There's 8 cervical, 12 thoracic, 5 lumbar, and 1 coccygeal. And these correspond with pair nerves. There's upper motor neurons, corticospinal and corticobulbar traces, which are contained in the CNS, and the lower motor neurons, which are the cranial and spinal efferent neurons, which are responsible for the direct influence on muscles. The peripheral nervous system, the cranial and spinal nerves, including the branches and the ganglia. We have axons and dendrites, and most are wrapped in a myelin sheath. Now, these coverings provide structural support, blood supply, and interstitial compartments necessary for the delivery of electrolytes and support nerve impulse conduction. There's 31 pairs of spinal nerves, and these derive their names from the vertebral level from which they exit. Spinal nerves contain sensory and motor neurons, or considered mixed nerves. Dermatomes are specific areas of cutaneous innervation at the spinal cord segments. And the cranial nerves, which are categorized as peripheral nerves. Most of these are mixed, although some are purely sensory or some are purely motor. And these arise from the nuclei in the brain and the brainstem. The autonomic nervous system, there's components of the ANS are located in the central nervous system and the peripheral nervous system. The autonomic nervous system is considered part of the efferent division of the peripheral nervous system. The peripheral autonomic nerves carry mainly efferent fibers, and there's 2 neuron systems, preganglionic or myelinated and postganglionic or unmyelinated neurons. The ANS coordinates and maintains a steady state among visceral organs, such as cardiac muscles, smooth muscles, and glands. And this is an involuntary system. And it's divided into the sympathetic and parasympathetic systems. Now, the sympathetic is the fight or flight. That's functions to mobilize energy stores in times of need. Parasympathetic functions to conserve and restore our energy. All right, pain, temp, sleep, and sensory function. Let's start with some pain. Now, pain is one of the body's most important adaptive and protective mechanisms. It is a complex phenomenon and cannot be characterized only as a response to injury. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There's different pain theories, such as the specificity, pattern, gate control, and neuromatrix theories. You can read more about those in the textbook. We have nociceptors, which are free nerve endings in the afferent peripheral system that selectively respond to different chemical, mechanical, or thermal stimuli. The A delta fibers, these are lightly myelinated. They are medium-sized fibers, and these are stimulated by severe mechanical deformation or by mechanical deformation and or extremes in temperature. These rapidly transmit sharp, well-localized, fast pain sensations, and there is a reflex withdrawal of the affected body part. Think of it as when you touch a hot stove, you touch that hot plate and you automatically, your hand is drawn, you draw your hand away. C fibers, these are smaller, these are unmyelinated, polymodal, and are stimulated by mechanical, thermal, and chemical nociceptors. These slowly transmit dull, aching, or burning sensations. And then they have the A beta, which are large myelinated fibers that transmit touch and vibration sensations. And these do not normally transmit pain, but they do play a role in pain modulation. Acute pain, this is a protective mechanism. This alerts the person to a condition or experience that is immediately harmful to the body, and it mobilizes the individual to take prompt action to relieve it. This is transient, and it can last from a few seconds to days or may last up to 3 months. It begins suddenly and is relieved after the chemical mediators that stimulate pain receptors are removed. Stimulation of the autonomic nervous system occurs, and there can be physical manifestations such as an increased heart rate, hypertension, diaphoresis, and dilated pupils. This arises from cutaneous and deep somatic tissue or from visceral organs. Somatic pain is considered superficial. It arises from connective tissue, muscle or bone, or skin. It is sharp or well localized or dull when the A delta fibers are involved, or it can be aching, throbbing, or poorly localized when there's C fiber transmission. Visceral pain, internal organs or the lining of the body cavities. This can be aching, gnawing, throbbing, or intermittent cramping quality. And this is transmitted by sympathetic afferents and is poorly localized. It's associated with nausea, vomiting, hypotension, restlessness, and shock. And it often radiates or is referred. Now, referred pain, this is pain in the area removed or distant from its point of origin. The area of referred pain is supplied by the same spinal segment as the actual pain site. That's why you feel it in a different area. The impulses from many cutaneous and visceral neurons converge on the same ascending neuron, and the brain cannot distinguish between the two. And referred pain can be with acute or chronic pain syndromes. Okay, chronic pain. Now, this is pain that's lasting at least 3 months and is well beyond the expected healing time following the initial onset of tissue damage or injury. This often appears out of proportion to any observable tissue injury. This may be ongoing, such as with low back pain, or intermittent with situations with like migraines. There's changes in the PNS and CNS that cause dysregulation of nociception and pain modulation processes. Neuropathic pain. This results from primary injury to the PNS or CNS and is not the result of pain signaling from the peripheral tissues or organs. Chronic neuropathic pain leads to long-term plastic changes along somatosensory pathways from periphery of cortex and abnormal processing of sensory information by the PNS and the CNS. The peripheral and central mechanisms of pain sensitization. And we have peripheral neuropathic pain, which is peripheral nerve trauma, which we might see in patients with diabetes or alcohol abuse. Central neuropathic pain is a lesion or dysfunction in the central nervous system. Hemiagnosia pain, which is a form of central pain associated with stroke that produces paralysis and hypersensitivity. Phantom limb pain, where there's pain in the amputated limb after that stump is healed. And sympathetically mediated pain, which is after peripheral nerve or extremity injury. Okay, temperature regulation. There's precise balance of heat production, heat conservation, and heat loss. Now, our normal temperature range, 97.2 up to about 99.9, and it usually hovers around 98.6 degrees in humans. Not all parts of the body have the same temperature. The internal temp varies with activity, environmental temperature, and circadian rhythm, and with the menstrual cycle in women. Our temperature peaks around 6 p.m. and it is lowest when we are sleeping. Hypothalamic control of temperature. Thermal regulation is mediated by the hypothalamus. There's peripheral thermoreceptors in the skin and the abdominal organs, and these are unmyelinated C fibers and thinly myelinated A delta fibers. The central thermoreceptors in the spinal cord and other central locations. And these provide the hypothalamus with information about the skin and the core temperatures. So those thermoreceptors are telling the hypothalamus what's going on in the body. The hypothalamus responds to lower high temps by triggering heat production, heat conservation, or heat loss mechanisms. And the endocrine system also operates to control the body temperature. Mechanisms of heat production. Increased heat production, there's hormonal mechanisms involving the hypothalamus and its connection to the endocrine system. Chemical reactions of metabolism. There's ingestion and metabolism of food and to maintain the body at rest. And this occurs primarily in the liver. Skeletal muscle contraction, there's an increase in muscle tone and production of rapid muscle oscillations, also known as shivering. And there's chemical thermogenesis, which is the release of epinephrine and norepinephrine. Mechanisms of heat loss. We have radiation, which is heat loss through electromagnetic waves. Conduction, which is heat loss through direct molecule-to-molecule transfer from one surface to another. Vasodilation, which is diverting core warmed blood to the surfaces of the body. Decreased muscle tone may be moderately reduced and voluntary muscle activity curtailed. Evaporation or sweating, insensible water loss without sweating. Increased pulmonary ventilation. There's exchanging air in the environment through normal pulmonary ventilation, and this provides some heat loss, but it's minimal in humans. Voluntary mechanisms. High temperature may cause the individual to stretch out or take it easy. You're feeling hot, or you're feeling, you just want to take measures to eliminate that heat loss. And adaptation to a warmer climate, a period of adjustment from colder to warmer weather. Okay, excuse me, I had a little bit of a distraction. Voluntary mechanisms. High temp may cause individual to stretch out or take it easy. And adaptation to warmer climates, there's a period of adjustment from cooler to warmer weather. Now, mechanisms of heat conservation. There's two mechanisms: involuntary vasoconstriction, which is mediated by the sympathetic nervous system. There's vasoconstriction of the peripheral blood vessels, and centrally warmed blood is shunted away from the periphery to the core so heat can be maintained. Voluntary mechanisms: when there's cold weather, we might bundle up or keep moving around, jump around some to kind of conserve some heat. Fever, this is also known as a febrile response or pyrexia, the temporary resetting of the hypothalamic thermostat to a higher level in response to endogenous or exogenous pyrogenes. Now, exogenous, the most common is the lipopolysaccharide complex and a cell wall of gram-positive bacteria and viruses. When we get an infection with a bacteria virus, that's when we can end up with a fever. Endogenous, prostaglandin E2, interleukin-1, interleukin-6, tumor necrosis factor alpha, and interferon gamma. We often want to treat a fever, but a fever is beneficial. It's an adverse effect on the growth and replication of microorganisms. There's a decrease in levels of the serum iron, zinc, and copper, and those are needed for bacterial replication. The body switches from burning glucose to a metabolism-based lipolysis and proteolysis to deprive the bacteria from a food source. Lysosomal breakdown and autodestruction of cells, and it prevents viral replication. Hyperthermia, this is an elevation in body temp without an increase in the hypothalamic set point. This can produce nerve damage, coagulation of cell proteins, and death. At 105.8 Fahrenheit or 41 Celsius, there can be nerve damage that produces convulsions in adults or febrile seizures. At 109.4 or 43 degrees Celsius, death will occur. Now, hyperthermia can be therapeutic or accidental. Therapeutically, we might use it for local, regional, or whole body-induced hyperthermia to destroy microorganisms or tumor blood flow. Accidentally, this can happen: heat cramps, heat exhaustion, heat stroke, malignant hyperthermia. Heat stroke was a big one in Florida where I worked and practiced for many years. Heat stroke, potentially lethal result of overstressed thermoregulatory center, heat loss through evaporation, and important to note that sweating ceases or stops, and the core temp rises. And the diagram here just shows some differences between heat exhaustion and heat stroke and what you should do in those instances. Hypothermia, this is when the body temperature drops below 95 degrees Fahrenheit or 35 degrees Celsius. There's vasoconstriction, shivering, alteration in microcirculation, coagulation, and ischemic tissue damage. This also can be accidental or therapeutic. Accidentally, the person might fall through the ice into a frozen, a really cold lake. There can be prolonged exposure to cold in the outdoors that causes hypothermia. Therapeutically, it can be used to slow metabolism and preserve ischemic tissue after brain trauma or during brain surgery, after cardiac arrest, and in neonatal hypoxic encephalopathy. Disorders of temperature regulation. Major trauma has a varying effect on temperature regulation. 5 different types: central nervous system. The temp may go up to 102.2 with CNS damage, inflammation, increased or intracranial pressure, intracranial bleeding, and neurogenic or central fever. Accidental injuries, this varies with the extent of the accident. Hemorrhagic shock, the blood loss triggers peripheral vasoconstriction and hypoxia, and this leads to hypothermia. Major surgery, a significant hypothermia through exposure of body cavities to a cold environment, such as in the operating room with cold IV solutions or anesthetic agents. Thermal burns, large burn injuries can cause significant hypothermia because there's that loss of the skin barrier to fluid evaporation. Sleep, this is an active, multi-phase, complex brain process that provides restorative functions and promotes memory consolidation. The suprachiasmatic nucleus controls the timing of the sleep-wake cycle, and it coordinates the cycle with circadian rhythms. There's two phases in sleep, non-REM and REM. Non-REM is about 75 to 80% of our sleep time, and this is initiated by the withdrawal of neurotransmitters. REM is about 20 to 25% of our sleep activity, and the brain is active with vivid dreams whenever we go into REM sleep. We usually only remember them, though, when we wake up during our dreams. There may be atonia of muscles, suppressed temperature regulation, alteration in heart rate, blood pressure, and respirations in REM sleep. Sleep disorders, dysomnias. Now, dysomnias are sleep disorders related to difficulty in initiating and maintaining sleep, or it can be the presence of excessive sleepiness. Insomnia is the inability to fall or stay asleep. This can be primary or secondary. Primary is transient and may be related to travel, disrupted sleep schedules, acute stress, something's going on in our life that's making it difficult for us to go to sleep or stay asleep. Secondary, it can be from drug or alcohol abuse, chronic pain, depression, obesity, and aging. Obstructive sleep apnea. This is a disorder of breathing related to upper airway obstruction that is associated with reduced blood oxygen saturation and hypercapnia. And this is more common in older adults and in patients who are obese. Restless leg syndrome, this is a sensory motor disorder associated with this unpleasant sensation that occurs at night, and the person feels this urge to move their legs around to get some relief from that sensation. Hypersomnia, there's excessive daytime sleepiness, and it's associated with voluntary sleep deprivation. Narcolepsy or hypersomnia, cataplexy, there's brief spells of muscle weakness, can have hallucinations and sleep paralysis. And circadian rhythm, sleep disorders such as jet lag, going from one extreme to another in a much different time zone, can cause us to have jet lag, difficulty getting into that circadian rhythm again. There's alterations in sleep schedule and changes in total sleep time. Okay, alterations in cognitive systems, cerebral hemodynamics, and motor function. Acute confusional states. These are transient disorders of awareness. These are associated with cerebral dysfunction, can be caused by drug intoxication, alcohol or drug withdrawal, metabolic disorders such as hypoglycemia or a thyroid storm, nervous system disease, trauma, surgery, febrile illness, heat stroke, and electrolyte imbalance. Can also be associated with systemic diseases such as heart, kidney, or liver failure, head injury, anesthesia, or focal cerebral lesions. Delirium. Now, this is a hyperkinetic confusional state, and this is an acute situation. It's an acute state of brain dysfunction associated with right middle temporal gyrus or left temporal occipital junction disruption. Neurotransmitters, there's increased levels of acetylcholine, dopamine, and serotonin, and decreased levels of GABA. Inflammatory cytokines such as interleukins, interferon, and tumor necrosis factor alpha, these alter the blood-brain barrier. There's excited delirium syndrome, which is agitated delirium and can lead to sudden death. Hypoglycemia, thyroid storm, seizures, cocaine or methamphetamine intoxication, and or catecholamines can induce fatal arrhythmias. Hypokinetic confusional states, there's right side frontal basal ganglion disruption, metabolic disturbances, interfering with the neuronal metabolism or synaptic transmission, and this can be from drugs or toxins. And there's just some different symptoms that go along with delirium. More on delirium, there's impaired or lost detection, clinical manifestations, confusion, inability to focus or maintain attention. The patient may have delusions or hallucinations. This is due to dysfunction of the anterior cingulate gyrus. There's ability to focus, sustain, or shift attention is seriously impaired or it's completely lost. Onset is usually abrupt, and this is an acute situation. Causes can be ANS or autonomic nervous system overactivity, such as patients who are in the intensive care unit, post-operative patients, those who are withdrawing from CNS depressants, such as alcohol or narcotics. Patients may have violent behavior, tremor, and seizures. And again, this is an acute medical condition. We need to identify the cause and contributing factors and treat this right away. To differentiate this from delirium, there's a table in the textbook that compares the two that you can review for more information, but we're also going to go over some information on dementia. This is a progressive failure. Remember, delirium was acute, dementia is progressive. And it's a progressive failure of many cerebral functions that includes impairment of intellectual function with a decrease in orienting, memory, language, executive attention functions, and alterations in behavior. The greatest risk factor for this is age. The mechanisms leading to dementia, there's neurodegeneration, genetics, inflammation, and biochemical alterations involved here. Atherosclerosis, there can be multiple foci of infarction. Trauma, such as lesions and cerebral convolutions. And compression, increased intracranial pressure, and chronic hypocephalus. There's a genetic predisposition to it, and there's some tables on dementia in the textbook that you can review as well. And here is just some different changes that are going on with the patient with dementia. Okay, Alzheimer's disease. The leading cause of, this is the leading cause of dementia and one of the most common causes of severe cognitive dysfunction in older adults. There can be non-hereditary or sporadic, late onset AD, which is the most prevalent form at about 70%. Greatest risk factors, age, and family history. Other risk factors include diabetes, midlife hypertension, hyperlipidemia, midlife obesity, smoking, depression, cognitive inactivity, or low educational attainment, female gender, estrogen deficit at menopause, physical inactivity, head trauma, and neuroinflammation. But the exact cause is unknown. Early onset familial AD is autosomal dominant. There's 3 gene defects, the APP, the PSEN1, and PSEN2. Late onset Alzheimer may be associated with chromosome 19, which is involved with the apolipoprotein E gene. Sporadic AD, most common and does not have specific gene association, but cellular pathologic mechanisms are the same as early and late onset Alzheimer's disease. Alzheimer, more on Alzheimer pathological alterations that are occurring. There's neuritic plaques, and these contain a core of amyloid beta protein, neurofibrillary tangle, which is involved with the tau protein, and clinical manifestations. There's a long preclinical and prodromal course. This is going on over years or decades before the appearance of clinical dementia is even seen. Mild short-term memory can go to total loss of cognitive and executive functions. Patients are progressively forgetful. There's memory loss, confusion, disorientation, and mental status changes. Frontotemporal dementia. This is rare, severe degenerative disease of the frontal and anterior frontal lobes that produces death of tissue and dementia. Onset is over 60 years of age. 3 different clinical presentations: behavioral variant frontotemporal dementia, semantic dementia, and progressive non-fluent aphasia. Clinical presentation, it's associated with the region of brain atrophy and patterns of cellular atrophy. There's an autosomal dominant pattern of inheritance in about 30 to 50% of the cases of frontotemporal dementia. The majority of cases involve mutations of genes encoding for the tau protein or progranulin. And this is often difficult to distinguish from Alzheimer's disease. More on frontotemporal dementia. Oops, nope, that's the same slide. I don't know why I have the same slide in there twice. Seizures, okay. These represent a manifestation of disease and not a specific disease entity. Seizure is a sudden transient disruption in brain electrical functioning caused by abnormal, excessive, hypersynchronous discharges of cortical hormones. Epilepsy, this is where there's a recurrence of seizures and there's no underlying correctable cause. A convulsion is a tonic-clonic, jerky, contract, relax type movement associated with some seizures. We have general seizures, which are 30% of seizures. They involve neurons bilaterally and often do not have a focal or local onset, usually originating from the subcortical or deeper brain focus. Focal seizures are partial. There's unilateral neurons, focal local onset, and these originate from discrete areas, usually associated with structural abnormalities localized to the cortical brain tissue. Consciousness may be maintained through these. Partial seizures may become generalized to involve neurons of the other hemisphere and the deeper brain nuclei, which is secondary generalization. More on seizures, initiation. There's two simultaneous events in a group of neurons, high frequency bursts of action potentials, and hypersynchronization. The tonic phase, there's excitation spread through the subcortical, thalamic, and brainstem areas. There's increased muscle tone, loss of consciousness, and apnea. In the clonic phase, there's alternating contraction and relaxation of the muscles. Now, there's a condition called status epilepticus, and in adults, it's a state of continuous seizures lasting more than 5 minutes, rapidly recurring seizures before the person has fully regained consciousness from a preceding seizure, or a single seizure lasting more than 30 minutes. And now post-ictal, this is the state that follows an epileptic seizure and returns to baseline. Parkinson's disease, this is a complex motor disorder accompanied by systemic non-motor and neurologic symptoms. There's degeneration of the basal ganglia. Parkinsonism, there's nigrostriatal disorder that produces a syndrome of abnormal movement. This is classified as primary or secondary, and there's a table in the textbook gives more information on that. Pathogenesis of primary is unknown, but there are several genes identified as contributing to this. Hallmark feature of Parkinson is a loss of dopaminergic pigmented neurons in the substantia nigra. There's a dopamine loss in other areas of the brain, such as the brainstem, the thalamus, and the cortex. Clinical manifestations, this has an insidious onset. It takes time for this to develop. Symptoms appear after 70 to 80% loss of pigmented nigral neurons and 60 to 90% loss of striatal dopamine. Classic motor manifestations, patients have a resting tremor, bradykinesia or akinesia, rigidity or plastic or cogwheel rigidity, and postural abnormalities. Evaluation, the diagnosis is based on these 4 cardinal symptoms: resting tremor, cogwheel rigidity, akinesia, and postural instability. Some more symptoms that we might see here are also these listed here on this diagram. Okay, disorders of the CNS and PNS and neuromuscular junction. Traumatic brain injury. This is where we have an alteration in the brain function and evidence of brain pathology caused by an external force. There can be closed or blunt trauma, which is such as the head striking the hard surface, or an open penetrating trauma where there's a break in the dura mater and it results in exposure of the cranial contents outside of the skull. The Glasgow Coma Scale, this can be used to assess the severity of injury. Focal brain injury, there's specific grossly observable brain lesions that occur in a precise location, such as cortical contusions or epidermal hemorrhage. We can have a coup, which is directly below the impact point, or a contra-coup, which is on the pole directly opposite of the site of impact. So coup, it's hitting the side where we hit. Contra-coup, the brain is going in the backwards in the brain, and it's affecting this area of the brain. Contusions are just blood leaking from an injured vessel. These are found most commonly in the frontal lobes. An extradural hematoma may develop that's bleeding between the dura mater and the skull. And a subdural hematoma, which is often due to an MVA, a motor vehicle accident, skull fractures, or falls in the elderly. More on traumatic brain injury. This is diffuse brain injury and involves widespread areas of the brain. It can be a mild concussion, also considered a mild TBI. This is immediate but transitory clinical manifestations. The CSF pressure rises, ECG and EEG changes without loss of consciousness, and this is graded 1 through 3. The classic cerebral concussion, this is a grade 4. This is when there's loss of consciousness, which may last up to 6 hours and is accompanied by retrograde and antegrade amnesia. Post-concussive syndrome, this may last for weeks or months, where the patient has headaches, nervousness, anxiety, irritability, insomnia, depression, forgetfulness, and fatigue. Diffuse axonal injury, or DAI, can be mild, moderate, or severe. Mild, post-traumatic coma that lasts 6 to 24 hours. Moderate is widespread physiologic impairment that exists throughout the cerebral cortex and the diencephalon. And severe, when there's severe mechanical disruption of many axons in both cerebral hemispheres and those extending to the diencephalon and brainstem. Spinal cord trauma, primary spinal cord injury, there's an initial mechanical trauma or immediate tissue destruction. Vertebral fractures and dislocations cause bone fragments to compress and damage the nerves. The classification of vertebral injuries can be a simple fracture, which is a single break usually affecting transverse or spinous process. A compressed or wedged, which is a vertebral body is compressed anteriorly. Or comminuted, which is a burst, or a vertebral body is shattered into several fragments. Or there can be dislocation. Secondary spinal cord injury, pathophysiological cascade of vascular, cellular, and chemical events that begins within a few minutes after injury and continues for weeks. There can be edema, ischemia, excitotoxicity, inflammation, oxidative damage, and activation of necrotic and apoptic cell death. Cord swelling increases as the individual, cord swelling increases an individual's degree of dysfunction. So that cord swelling is dependent, or the degree of dysfunction is dependent on that cord swelling at times. Spinal shock, characterized by complete loss of reflex function, flaccid paralysis, sensory deficit, and loss of bladder and rectal control in all segments below the level of the injury. Neurogenic shock occurs with cervical and upper thoracic cord injury and may be seen in addition to spinal shock. Okay, cerebrovascular disorders, a CVA, a cerebrovascular accident or a stroke. This is the most frequently occurring neurologic disorder. Cerebrovascular disease is any abnormality of the brain caused by a pathological process in blood vessels. CVA or stroke is the third leading cause of death in the United States. The incidence is about 2 times higher in Blacks than in whites. An ischemic stroke accounts for about 87% of all strokes, and those can be thrombotic or embolic. Intracerebral hemorrhage accounts for about 10%, and subarachnoid hemorrhage accounts for about 3%. There's a lot of risk factors for CVA. Those are listed in the textbook for you to review. Ischemic, a thrombotic stroke, there's arterial occlusion caused by thrombi or a clot, most commonly attributed to atherosclerosis and inflammatory disease. There's increased coagulation that can lead to thrombus formation, and conditions causing inadequate cerebral perfusion increase the risk for thrombosis. Transient ischemic attacks, or TIAs, these are transient episodes of neurologic dysfunction. Brain imaging often reveals brain infarction that requires an intervention. And in about 30% of those with a TIA, they will have a stroke within a year, so prevention is very important. Embolic stroke, fragments that break down a thrombus formed outside of the brain or heart, aorta, or carotid artery. Cerebral infarction, the area of the brain loses blood supply and becomes ischemic because of vascular occlusion. And a lacunar stroke, which is a microinfarct smaller than 1 centimeter in diameter and involves occlusion of the small perforating arteries. Hemorrhagic stroke, this is spontaneous bleeding in the brain. It's the third most common cause of a CVA. Risk factors include hypertension, previous cerebral infarct, coronary artery disease, diabetes mellitus. Most common causes are hypertension or a ruptured aneurysm, AV malformation and fistula, amyloid angiopathy, or a cavernous angioma. This can occur secondary to a traumatic brain injury, a bleeding disorder, or anticoagulation therapy. Clinical manifestations vary according to the location and the size of the bleed, but here are some different changes that may occur in the patient with a stroke. Headaches, we have migraines, cluster headaches, tension type headaches that we're going to talk about. Migraines are episodic neurological disorder. It's a headache lasting 4 to 72 hours. They're multifactorial disorder, and it's a combination of genetic and environmental factors with migraines. There's clinical phases of a migraine: premonitory, migraine aura, headache, and the recovery phase. Migraine can occur with an aura or without an aura. And a migraine without aura is often located on one side of the head. And a migraine with aura, most common prodromal symptoms are visual, so might have some visual auras, but they can also have it from other sensory areas, and it can also have aphasia. Cluster headache, trigeminal autonomic cephalgia. This is most common in men 20 to 50 years of age, occur in clusters for periods of days followed by long remission, and the triggers are similar to that of a migraine. Tension type headache, most prevalent type of primary headache. We get these when we're a little stressed out and have too much tension in our lives. Mild to moderate bilateral headache with sensation of like a tight band or pressure around our head. This can be episodic or it can be a chronic issue. Multiple sclerosis. There's chronic inflammatory disease, and this involves degeneration of the CNS myelin, scarring or formation of plaque, and loss of axons. This is an autoimmune response to self-antigens in genetically susceptible individuals. Most prevalent in whites, females, ages 20 to 40, and the peak age of incidence is 30. It's a leading cause of neurologic disability. There is diffuse and progressive CNS disease that affects white and gray matter. Clinical manifestation, there's a variety of events. Different things like an infection, trauma, or pregnancy can spark this, that occur immediately before the onset of an exacerbation of symptoms, and these are considered to be precipitating factors. These can be classified as relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. 90% of are relapsing remitting, about 10% are primary progressive, and 90% develop a progressive course in 10 to 20 years from onset. Guillain-Barré syndrome, this is an acquired acute inflammatory demyelinating or axonal polyneuropathy with 4 subtypes. It's an autoimmune disease, and it can be triggered by a preceding viral or bacterial infection and can be associated with vaccines as well. Clinical manifestations are going to vary with the subtype. Some manifestations, first, the patient may experience numbness, pain, paresthesias, and weakness in the limbs. Motor signs manifest as acute or subacute progressive paralysis. The proximal muscles may be involved earlier and more significantly than distal muscles. There's paresis, paralysis that may be present in the ascending pattern involving limbs, respiratory muscles, and bulbar muscles. Only bulbar muscles may be involved and cause dysphagia and dysarthria. Weakness plateaus or improves by the 4th week in about 90% of the cases. Diagnosis is made by clinical history, examination of the cerebrospinal fluid, nerve conduction studies can be done, such as an EMG. The CSF may show unusually high protein levels. Treatment, ventilatory support, because that issue with those bulbar muscle involvement, the patient may have need management of the ANS dysfunction. There's IV immunoglobulin, plasmapheresis, plasma exchange, or a combination therapy within the first 2 weeks of the onset of the clinical manifestations. These patients will need aggressive rehab after the disorder begins to remit. Okay, psychological alterations. Schizophrenia. This is a serious psychiatric illness, affects about 1% of the population, and it's equally prevalent in males and females. Diagnosis is often late teens or early 20s. There's prenatal exposure that leads to schizophrenia. It could be to a viral infection, prenatal nutritional deficiencies, or perinatal complications. Brain abnormalities originate in the prenatal period. There's relin, which is the EC matrix protein that's reduced in prefrontal cortex. And there's dorsolateral prefrontal cortex appears to be hypoactive. It's a collection of illnesses characterized by thought disorders, a reflex, a break in reality, or a splitting of the cognitive and the emotional side of one's personality. And an example of this, the patient may exhibit a feeling of happiness when they're talking about a very traumatic or terrible event. Patients may have positive, negative, or cognitive symptoms. Positive symptoms frequently occur during a psychotic episode. And this is where the individual loses touch with reality, may have hallucinations, delusions, positive formal thought disorder, and bizarre behavior. Negative symptoms, there's disruptions in the normal emotional states and expression. Patient may have a flat affect, alogia, anhedonia, asociality, attention, and evolution apathy. Cognitive, this is fairly common and involves problems with thought processes that severely impair the ability to perform daily tasks, have lack of insight, and difficulty with memory. Diagnosis made by the presence of delusions, hallucinations, negative symptoms, or social occupational dysfunctions for 6 months, and at least 2 common symptoms of the disorder, such as delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. Treatment is going to be with antipsychotic medications, psychological therapy, cognitive behavioral therapy. Now the psychotic dimension with schizophrenia. Let's look more at hallucinations and delusions. These reflect a person's confusion or loss of touch with the external world. And a hallucination is a perception experienced without external stimulation of sense organs. Hallucinations can be auditory, tactile, visual, gustatory, and olfactory. Now, delusions, these are persistent belief contrary to the educational and cultural background of the individual. Delusions can be grandiose, nihilistic, persecutory, somatic, sexual, and may have religious themes as well. Paranoid beliefs are common, such as somebody spying on them, there's a conspiracy against them, there's persecution, and there's ridicule by others in part of their paranoid beliefs. Disorganized behavior. Patient may have disorganized speech or disorganized behavior. Disorganized speech, there's a formal thought disorder, fluent speech that is difficult to comprehend. Speech moves from one topic to another unexpectedly and illogically, and we just can't follow what the patient is even saying. There can be poverty of content, which means the same phrases are used repeatedly throughout the conversation. Disorganized behavior, there's conceptual equivalent of disorganized speech. There's difficulty engaging in goal-directed activities. Patient may have repetitive or aimless behavior, pacing around, something like that. And they can also have poor personal hygiene as well. Negative dimensions with schizophrenia. These reflect a deficit in normal functioning and are characterized by affective flattening, anhedonia, alogia, and avolition. And a closer look at those. Affective flattening, there's like a near absence of emotional or facial expression throughout a conversation or in different situations. Anhedonia, there's an unable to experience emotions such as pleasure or pain and report a sense of detachment from the environment. Alogia, absence of spontaneous speech production for the purpose of answering questions or expressing oneself. And avolition is just a deficit in spontaneous or goal-directed behavior, such as completing simple daily tasks. Depression, this can be classified as unipolar or major depressive disorder, or bipolar disorder, and that can be broken down into bipolar 1 or 2. Major unipolar depression is most common mood disorder, and it's a leading cause of disability in the United States. There's hypothalamic pituitary adrenal HPA system abnormalities. Stress-induced depression shows atrophy of neurons in the hippocampus. There's unremitting feelings of sadness and feelings of despair. Dysphoric mood or an intensely painful mood accompanied by insomnia, loss of appetite, body weight changes, reduced interest in pleasurable activities, and in interpersonal relationships. They may have feelings of worthlessness and may feel guilt. Ability to function and concentrate is greatly diminished. And there is a suicidal risk with patients in depression, and we have to evaluate for that risk. Lab-wise, we might see some elevated pro-inflammatory cytokines and cortisol. Treatment can be with MAOI inhibitors, TCAs or tricyclic antidepressants, or SSRIs. Now, SSRIs are the standard first-line treatment. MAOI inhibitors aren't really used very much anymore. These can cause a hypertensive crisis, so those just you don't see prescribed as much anymore. Now, bipolar disorder, we have 1 or 2. Bipolar 1, manic episodes and at least 1 major depressive episode. Bipolar 2, there's recurrent major depressive episodes with 1 or more hypomanic, milder than manic episodes. Treatment, it's important to note that antidepressants may lead to cycle acceleration or induction of mania, so this needs to be treated cautiously. SSRIs or bupropion may be less likely to induce these effects than MAOIs or TCAs. Bipolar 1, often treated with lithium to control mania and rapid cycling and to reduce suicide risk. You may combine that with an SSRI. Other treatment includes anticonvulsants or atypical antipsychotics. Serious side effects of lithium is toxicity, so patients need to have their blood monitored to make sure they're staying in a therapeutic range. Bipolar 2, less severe form of mania. Treatment focuses on recurrent depressive symptoms. This can be treated with escitalopram, fluoxetine, or venlafaxine. More on bipolar mania. Manic individuals experience elevated levels of euphoria and self-esteem and have feelings of grandiosity. Energy levels are greatly enhanced even after only a few hours of sleep. They may have poor judgment in spending money, be hypersexual, and have poor business commitments. They may have excessive, rapid, loud, pressured speech. And there can be psychotic symptoms such as delusions or hallucinations. Anxiety disorders, fear and anxiety become too intense and undermine the ability to function on a daily basis. This is the most prevalent psychiatric illness, and many anxiety disorders develop major depression. DMS-4-TR, there's 8 recognized anxiety disorders: panic disorder, agoraphobia, generalized anxiety disorder, social phobia, specific phobia, OCD, PTSD, and acute stress disorder. Now, panic disorder, there's multiple disabling panic attacks, and it's characterized by intense autonomic arousal involving a wide variety of symptoms, including lightheadedness, tachycardia, difficulty breathing, chest discomfort, sweating, general weakness, trembling, abdominal distress, chills, and hot flashes. And patients often with that difficulty breathing and chest discomfort, tachycardia, sometimes might feel as though they're having a heart attack. Between panic attacks, they worry about future panic attacks and fear of losing control and dying. Complication, agoraphobia, avoid places or situations where escape or help is not readily available. There's genetic factors involved. Panic-prone individuals respond to chemicals called panicogens, carbon dioxide, caffeine, cholecystokinin, sodium lactate, and adrenergic receptor antagonists. The GABA benzodiazepine receptor system may be involved. Treatment with cognitive behavioral therapy and antidepressants. Cognitive behavioral therapy, want to teach patients that physical symptoms are not fatal and learn strategies to control, have control over their anxiety and their panic. And those can include breathing exercise, and you want to make sure patients are compliant with their medications. Antidepressants that can be used: SSRIs, paroxetine, venlafaxine. Benzodiazepines might be used, such as alprazolam or Xanax, clonazepam. These should be used for short-term use, as they can become dependent and addictive. And there's a risk, again, for physiologic and psychological dependence on the benzodiazepine, so you want to treat with those cautiously and intermittently. Generalized anxiety disorder, there's excessive and persistent worrying. This condition is slightly higher in women than men. 6 major symptoms: restlessness, muscle tension, irritability, easily fatigued, difficulty concentrating, and difficulty sleeping. These are complications of substance abuse, or excuse me, a complication is substance abuse. Diagnosis: the person spends at least 6 months worrying excessively and engages in at least 3 of the 6 major symptoms. Treatment can be with venlafaxine or SSRIs, paroxetine, or escitalopram. Also effective in treating depression, and behavioral therapy can be beneficial as well. Post-traumatic stress disorder, PTSD. This is exposure to a terrifying or life-threatening event, also known as shell shock, war neurosis, or traumatic neurosis. And it used to be associated a lot with those coming back in the military from war. But now we know that this can be caused by any horrific experience involving intense fear. And it may develop within hours of the traumatic experience. Individual re-experiences the traumatic event with intrusive flashbacks and persistent nightmares. They can have psychological distress, intense autonomic arousal, and avoidance behavior. There can be emotional numbing or detachment. There's amygdala and prefrontal cortex that are highly involved. Diagnosis: this is diagnosed according to the duration and timing of symptoms, and it may be acute or chronic. Treatment with paroxetine or sertraline, lessen recurrent nightmares and flashbacks to that medication. Obsessive compulsive disorder. This is repetitive intrusive thoughts and or compulsions. Thoughts and acts impair normal functioning and cause distress. There's obsessions or preoccupation with contamination, doubting, religious or sexual themes might be involved, or a belief that a negative outcome will occur if a specific act is not performed. Compulsions, these are physical and mental ritualized acts such as washing the hands, cleaning certain things, checking, counting, organizing, hoarding, or repeating specific thoughts or prayers. OCD and Tourette syndrome may share common genes, and pathophysiology is OCD. Abnormalities of the basal ganglia frontocortical circuitry. And treatment is with long-term treatment is with cognitive behavioral therapy and pharmacotherapy such as SSRIs. And clonazepam has been found to improve the effects of fluoxetine and chlorpramine therapy. Okay, alterations of neurologic function in children. The structure and function of the nervous system in children. There's genetics and environment that shape the nervous system development. Proper proportions of essential nutrients are necessary for growth and proliferation of the nervous system when the baby is developing. The CNS develops from a dorsal thickening of the neural plate, and this plate unfolds to form a neural groove and neural folds. This groove deepens in the 4th week of gestation and forms the neural tube. Embryonic development is in 6 stages: dorsal or posterior induction, ventral or anterior induction, proliferation, migration, organization, and myelination. Brain development, the bones are separated by suture lines and form 2 fontanelles or soft spots. The posterior fontanelle is open until about 2 to 3 months of age, and the anterior closes at about 18 months of age. Head circumference, a very important thing that we look at with infants to see if they're in the normal range with their head circumference or if there's any major changes to be alerted to. Structural malformations, there's defects in neural tube closure. Neural tube defects, these are caused by the rest of normal development of the brain and spinal cord during the 1st month of embryonic development. So this happens very early on, often caused by a folate deficiency. Myelodysplasia is a defect in the formation of the spinal cord and anomalies in the vertebral column and spinal cord. Anencephaly, this is an anomaly of soft bony component of the skull, and much of the brain are missing. These babies are usually born stillborn, or they die within a few days of birth. And encephalocele, a herniation or protrusion of various amounts of brain and meninges through a defect in the skull, and this results in a sac-like structure outside of the skull. Occurs during the 1st week of pregnancy, and a cranial meningeocele is the treatment, which is a surgical repair. A meningeocele and a myelomeningeocele, these are types of spina bifida. These are seen here on this diagram. It's an incompletely formed or absent vertebral arch in the spinal column. A meningeocele is a protrusion of a sac-like cyst of meninges filled with spinal fluid. And a myelomeningeocele is a similar sac-like cyst, but this one also has neural tissue, spinal cord, and nerves in it. And the neurotube fails to close completely. And manipulation of the sac prenatally or during the first 72 hours of life is how this is treated. Craniosynostosis, premature closure of 1 or more cranial sutures during the first 18 to 20 months of the infant's life. This is part of a syndrome, or it can be an isolated defect, which is the more common occurrence. Non-syndromic craniosynostosis. Simple is when there's 1 suture involved. Compound or complex is when 2 or more sutures are involved. Exact cause is unknown, and this is classified by head contour and suture involvement. And it's important to differentiate this from a benign skull deformity, such as positional plagiocephaly, in which there's flattening on one side of the head, often from the baby laying on one side versus the other. Malformations of cortical development. Now, there's structural malformations of cortical development. These are caused by an abnormal neuronal cell migration, abnormal neuronal and glial proliferation, and malformations secondary to abnormal post-migrational neuronal development. There can be microcephaly, which is a small brain, in which there's reduced proliferation or accelerated apoptosis. And this is a rare defect in brain growth. Cranial size is significantly below average. That's why, again, why we're looking at head circumference on infants. Primary microcephaly is present at birth, usually caused by genetic alterations, autosomal dominant, autosomal recessive, or X-linked or chromosomal abnormalities can lead to this. Secondary microcephaly develops postnatally, in which the head fails to grow, and this can be caused from infection, trauma, metabolic disorders, and maternal anorexia. There's increased proliferation that causes megaloencephaly or a large brain. Now, cortical dysplasias, there's defects in neuronal cell migration and subsequent abnormalities in connection between cells, vary from small areas of abnormal tissue to the entire brain being smooth with no gyri or sulci. Congenital hydrocephalus, this is present at birth and characterized by increased intracranial pressure. There's blockage within the ventricular system, imbalance of production of CSF, and reduced absorption of cerebrospinal fluid. Obstructive hydrocephalus, this is caused most commonly by congenital aqueductal stenosis. The fontanelles enlarge and become full and bulging, and the baby may have a staring expression, and the sclera may be visible above the iris, which is known as sun-setting eyes. Alterations in functions, encephalopathies. This is pathology involving the brain, general category of syndromes and diseases that include infection, ischemia, metabolic, and toxic causes. Static encephalopathies may develop from trauma near birth, such as cerebral palsy, genetic syndrome or intellectual disability, or later, such as with a closed head trauma. Cerebral palsy, there's a disorder of movement, muscle tone, or posture that is caused by injury or abnormal development in the immature brain, and this can occur before, during, or after birth up to 1 year of age. This is one of the most crippling disorders of childhood. Patients may have motor deficits, intellectual disability, and seizures. Prenatal factors affecting the development of the nervous system may be endogenous or exogenous. There can be anoxia, trauma, and infections, which are the most common factors involved here. Low birth weight and birth asphyxia, and there can be vascular abnormalities and thrombosis that can occur. And the diagram here is just showing different areas of the brain that can be affected and the resulting effect of it. Inherited metabolic disorders of the CNS, we do screening for about 28 different metabolic conditions. And a deficiency of an essential product or accumulation of a substrate with damage induced by overaccumulation or toxicity or both. Excuse me. Phenylketonuria, PKU, this is an inborn error in metabolism of amino acids. It's an autosomal recessive inborn error, and it's characterized by mutations of phenylalanine hydroxylase gene. There's an inability of the body to convert essential amino acid phenylalanine to tyrosine, and there's an accumulation of that phenylalanine and associated metabolites that cause damage to the CNS. So if this isn't treated, brain growth will slow, there'll be developmental delays, seizures, skin rashes, and attention problems. Acute encephalopathies, intoxications of the CNS. Drug-induced encephalopathies must always be considered in a child with unexplained neurological changes. There can be lead poisoning, in which high levels of lead get into the blood, and this can lead to encephalopathy and serious irreversible neurological damage. Pica, which is a habitual, purposeful, and compulsive ingestion of non-food substances such as clay, dirt, and paint chips. Now, infections of the CNS, we have meningitis. This is inflammation of the meninges and the subarachnoid space surrounding the brain and the spinal cord. Acute bacterial, this is one of the most serious infections to which infants and children are susceptible. There's different causes of it listed in the table in the textbook. The use of conjugate vaccines have decreased the incidence of meningitis. Group B streptococcus is a lethal meningitis and sepsis in newborns, and this is transmitted from the birth canal. That's why they will check for group B streptococcus in the birth canal before the delivery date. Infection is often preceded by an upper respiratory tract infection or a GI tract infection. Inflammation leads to general symptoms such as fever, headache, vomiting, irritability of the CNS, photophobia, and nuchal and spinal rigidity. Definitive diagnosis is made by examination of the cerebrospinal fluid. Now, viral meningitis, this is a hallmark, is a mononuclear response in the cerebrospinal fluid and the presence of a normal glucose level. Clinical manifestations are similar to that of bacterial meningitis, although they are usually more mild. Now, cerebrovascular disease can occur in children. There can be a perinatal stroke, and perinatal arterial ischemic stroke is estimated in about 1 to 4,000 live births and is a leading cause of perinatal brain injury, cerebral palsy, and lifelong disability. Now, this may not be diagnosed until later in infancy or in childhood. Childhood stroke and ischemic stroke is rare, may result from embolization, arteriopathy, or rarely a synovenous thrombosis. About 40% of kids with ischemic stroke have no identifiable risk factor for it. Sickle cell, cerebral arteriopathies, and cardiac anomalies are the most common disorders associated with a pediatric stroke. Hemorrhagic stroke, the most common cause is congenital cerebral arteriovenous malformations. Vascular anomalies may rupture, such as an aneurysm, and there's a risk of developing a post-hemorrhagic hydrocephalus. Symptoms of ischemic or hemorrhagic stroke may include degrees of hemiplegia, can be flaccid or spastic, weakness, seizures, headaches, high fever, nuchal rigidity, hemianopia, sensory changes, facial paralysis, and temporary aphasia. And finally, epilepsy. This is the occurrence of seizures. Highest onset is during the first 12 months of life. It's an abnormal discharge of electrical activity within the brain. When a sufficient number of neurons become overexcited, they discharge abnormally, which sometimes results in a seizure. There's dysregulation of inhibitory GABA, neurotransmission with imbalance of excitatory and inhibitory mechanisms. Now, epilepsy is more than one unprovoked seizure, except in the case of febrile seizures. A seizure may be a symptom of an underlying disorder, such as meningitis or a brain tumor. There is a genetic and familial predisposition. Now, partial seizures, it's in one part of either the right or the left hemisphere. Simple partial is without loss of consciousness, and complex partial is when there's impairment of consciousness. Generalized seizure, there's seizure activity that starts in or involves both cerebral hemispheres. Childhood absence epilepsy, there can be petit mal or non-convulsive epilepsy. There's a type of generalized seizure, interruption of ongoing voluntary activity accompanied by staring, mild eyelid fluttering, myoclonic jerks, and no aura. And hundreds of seizures can occur per day. Okay, that's all I have to cover. Please let me know if you have any questions. I thank you for your time. Have a great day.